Hey guys, okay, I'm back for part two. We just talked about fluoroquinolones. Now we're going to do tetracyclines. So tetracyclines include your doxycycline, which is available PO or IV, minocycline, which is also available PO IV, which I have not ever used at IV, but it is available. And then tetracycline was the old school first drug that was in this class. So these have really good atypical coverage. So your atypical bacteria, again, your Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella, those are the three big ones. And those are often culprits with community-acquired pneumonia. So atypical coverage, rickettsia, spirochetes, all of the kind of odd bacteria that don't really fall into any other category. Tetracyclines do have moderate staph and strep coverage, and doxy will cover community-acquired MRSA. Minocycline does have with it a warning for dizziness and vertigo, so just keep that in mind. And then we have the glycopeptides, which is a newer drug called Tigasil or tigacycline. It's available only in IV. It maintains that good atypical coverage. It's good for enterococci, staph, and strep. And it has acceptable coverage for gram-negatives, but it does not cover Pseudomonas, so keep that in mind. 3 Ps, actually, Pseudomonas, Proteus, or Providentia. So Tigasil is a big drug. We don't use it a whole lot in the hospital because it's very expensive. But it does cover enterococci, which is something to keep in mind, including vancomycin-resistant enterococci. Okay, and Tigasil does cover MRSA, so put that in your on your MRSA list. Caution for tetracyclines: the oral agents are chelating agents, so again, any cations that will bind with must be separated from any cation products. They can cause esophageal irritation, so make sure you counsel to take with a full glass of water. They cause photosensitivity, and we don't use tetracyclines in pediatric patients less than 8 because of the risk for teeth discoloration. So this is a good class of drugs, excluding tetracycline itself, for upper respiratory tract infections, for sinusitis, acute exacerbations of chronic bronchitis or COPD, community-acquired pneumonia, tick-borne disease, SSTIs, pelvic inflammatory disease, STDs, and malaria. So these tetracycline group covers a wide range of bacteria. Macrolides, these also, there's 3 macrolides. Erythromycin is the oldest, and that was the first one, available by mouth and IV. And really the only time I see erythromycin used these days is as a prokinetic agent because it causes diarrhea. So a lot of times in the hospital we'll use it, especially in patients like with the GI bleed. If they have blood in their stomach, we'll give them some IV erythromycin to try to push it through. Clarithromycin was the second development in this class of drugs. The brand name is Bactrim. It is available only by mouth. And then azithromycin is available by mouth and IV. The brand name is Zithromax. So on the spectrum of problems, these drugs have 2 things that you have to keep in mind. So QTC prolongation and drug-drug interactions with the CYP3A4 drugs and the P-glycoprotein drugs. So just keep that in mind, and they are going to be, the way that I have them listed, severity-wise. So azithromycin has less QTC prolongation, less drug interactions, and then clarithromycin has moderate amount, and erythromycin is pretty strong on both of them. So these are drugs that are good for upper respiratory tract infections, lower respiratory tract infections, STD, and they're also used to treat H. pylori. So these cover atypicals, H. influenza, Moraxella, H. pylori, and Mycobacterium. They have moderate staph and strep coverage. We do use them in combination with the beta-lactam for community-acquired pneumonia, and sometimes by themselves for a less severe community-acquired pneumonia. They have poor staph coverage, and they don't really cover enteric gram-negatives very well. No anaerobe or enterococcal coverage either. These drugs are bacteriostatic, as are the tetracyclines. So they're not going to be bactericidal. They don't break open that cell wall. So just keep that in mind. Glycopeptides, we have short-acting glycopeptide, which is vancomycin, available IV and PO. The oral vancomycin is only used for C. diff. So you will never see PO vancomycin used unless you're treating a C. diff infection. And these are vancomycin I mentioned, and telavancin is IV. So these are your shorter acting glycopeptides. They do cover most gram positives. They very good staph, especially MRSA coverage, strep, and C. diff when it's given by mouth. Moderate coverage for enterococci, plus or minus, and they don't really cover anything that's gram negative. So just keep in mind vancomycin is preferred for MRSA, not MSSA. So it actually works better for the methicillin-resistant Staph aureus. If you have a methicillin-sensitive Staph aureus, it's recommended that we don't use vancomycin. And then we also have long-acting glycopeptides, which are dalbavancin, Dalvance is the brand name, and oritavancin or Orbactive. Both of those are IV, and they are very long-acting. Usually in some indications only given once, so they may have an activity that lasts 7 days. They're only indicated for SSTIs, skin and soft tissue infections, so they have good staph coverage, especially MRSA, good strep, and good enterococci. So the dalbavancin has moderate coverage for enterococci, and you pick up more coverage for that with the oritavancin. So oritavancin would be the preferred agent for enterococci out of those two. And again, poor gram-negative coverage. All right, just a few others to go through. Monobactam is a class that includes aztreonam, brand name Azactam. It's only available IV. It does have good gram-negative coverage and Pseudomonas coverage. Moderate Acinetobacter, you wouldn't use it by itself for Acinetobacter, and it doesn't really cover gram-positives very well. The thing to know about aztreonam is it's safe to use with a beta-lactam allergy, and you'll often see it substituted when people have beta-lactam allergies for penicillin or ampicillin. Has a very similar spectrum to ceftazidime and actually is cross-reactive. So if your patient has an allergy to ceftazidime, you would not be able to use aztreonam. It can also be used via nebulizer for cystic fibrosis kids mostly, and you should not use it with other beta-lactams. The next class, aminoglycosides, we have gentamicin, tobramycin, and amikacin. There is a new one called plasmamycin that's not on this slide. We'll talk about it in class. But gentamicin, all of these, gentamicin, tobramycin come IV, ophthalmic, and topical. And then amikacin is also available in a nebulizer, as is tobramycin. So these are good gram negatives. They do cover Pseudomonas and Acinetobacter. Again, should not be used as monotherapy for either one of those, but they will cover the gram negative rods in combination. So they do have poor gram positive. You will see gentamicin and tobramycin used as synergistic coverage for endocarditis. So you'll see them used with a beta-lactam for endocarditis, but it's more of a synergy effect than an actual antibiotic effect. The nitrofurans and phosphomycin, these have good E. coli coverage, and they also cover Staphylococcus. Moderate coverage of the other gram negatives, best with E. coli. These are only used for UTIs. So nitrofurantoin is macrobid or macrodantin. It's given by mouth. Phosphomycin, the brand name is Monuril. It's also given by mouth, but it's a powder pack. So it comes in a little packet of powder that you mix with water, and it's only a one-time dose used for UTIs. The next we have Zyvox or linazolid and tadazolid, Cevextro. Zyvox is available by mouth and IV, and Cevextro is available only IV. These are primarily gram-positive coverage. They're good for staph and strep, including multi-drug resistant strep pneumo. Also good for enterococcus, including vancomycin-resistant enterococcus. So that these play a very specific role, especially when we have the vancomycin-resistant enterococci. They have moderate coverage of some atypicals, but it's not something that we think about as first line. They don't cover gram-negatives very well and no anaerobic coverage. So a couple things to keep in mind about Zyvox or linezolid does cause bone marrow suppression, and it is an MAOI inhibitor, so you can see serotonin syndrome when it's used in combination with other serotonin drugs. So just keep in mind the drug interactions with linezolid. The cyclic lipopeptides, daptomycin is the drug, brand name Cubicin. It's available only IV, super duper expensive. It does have good staph coverage, including MRSA. It will cover strep and enterococci, including VRE. It does have poor gram-negative coverage. So a couple points for Cubicin to keep in mind. You cannot use it for pneumonia. It's actually deactivated by lung surfactants. So you can't use it for pneumonia. You have to monitor the creatinine kinase weekly because it can cause some breakdown of muscle tissue. And it does have a drug-drug interaction with statins, which kind of goes along with that creatinine kinase. So those are some high-yield points for daptomycin. Metronidazole or Flagyl is another class of drug. It's available PO and IV, and it is the niche for metronidazole is anaerobes. Okay, so and it does cover protozoa too, but anaerobes is where you're going to see it used mostly. A couple things to remember about it does cause a disulfiram-like reaction with alcohol. So if you drink while you're taking Flagyl, if you drink alcohol, you're going to get very sick and throw up. It does cause a metallic taste, and it can also cause peripheral neuropathy. We're almost done. Folate antagonist, Bactrim or sulfamethoxazole trimethoprim is available PO or IV. Dapsone, pyrethramine, and sulfadiazine, sulfadoxine are the others. Those three are only available by mouth. So Bactrim does have good staph coverage. It covers community-acquired MRSA, not hospital-acquired, but community-acquired. It'll cover your H. influenza, listeria. It's got a kind of a broad range of coverage. It has moderate gram-negative coverage and strep pneumo coverage. It does not cover Pseudomonas, enterococci, or anaerobes. Bactrim does have it's a high yield drug as well. There's a severe drug-drug interaction with warfarin that you definitely need to be aware of that will require dose modification for warfarin. It can also cause bone marrow suppression and a rash. So just be aware of those things. Clindamycin is a lincosamide. It's in the class lincosamide. The brand name is Cleocin. It's available PO, IV, or topical. It has good anaerobic coverage, gram-positive anaerobic coverage. That's where you're going to see it used most often. It does cover gram-positive strep pyogenes, which is also kind of a unique niche. It has moderate Staph aureus coverage. It can sometimes be used for community-acquired MRSA, but we're starting to see more resistance with that. It has poor enterococcus, poor C. diff, and poor gram-negative coverage. Clindamycin is notoriously known for diarrhea and one of the biggest culprits that leads to C. diff. So just keep that in mind. We can also use it in combination with beta-lactams to reduce the effects of the exotoxins that are produced by beta-lactams or by the bacteria when the beta-lactam lyses the bacteria. So just kind of keep that in mind you'll hear us talk about that from time to time. And that is all I have. Please feel free to email me, call me, text me if I can help you with anything. If you have any questions about anything, this is just a very quick overview. The charts are here just to help you kind of organize your thoughts and get these antibiotics straight. So please let me know if I can help you with anything, and I look forward to seeing you in class in a couple weeks. Thanks.